Good afternoon, everyone. My name is Orbán Sándor, and let's talk about new insights on the treatment of metastatic gastroenteropancreatic neuroendocrine tumors. I'm a medical doctor and a first-year PhD student, and my vision is to advance the treatment of gastroenteropancreatic neuroendocrine tumors, improving survival and quality of life, and my mission is to find the best combination and sequence of treatment modalities for these patients. I have currently two ongoing projects. The first one is investigating the effect of primary tumor resection prior to PRRT and metastatic GEP-NET patients, and it will be conducted via a meta-analysis. The second one is investigating the safety and the effectiveness of surgical excision of primary tumor in well-differentiated metastatic PNET patients, and it will be conducted via SEER Registry Analysis. The SEER database is maintained by the National Cancer Institute. So as you can see, the two projects are very similar. That's why I prepared a general background slide about neuroendocrine tumors. Neuroendocrine tumors are rare malignancies rising in incidence and prevalence. The majority of them originate from the gastroenteropancreatic tract. Most of the patients will be metastatic already at the presentation. Liver failure caused by metastasis is the main mortality cause for these patients. The 5-year overall survival is 50%. Being a systematic disease, it requires systematic medical treatment. However, some studies suggest that resection of the primary tumor only can prolong progression-free survival and overall survival. In our study, we want to focus on well-differentiated neuroendocrine tumors, which by definition are tumors that have Ki-67 index lower than 20%. So the first project investigating the effect of primary tumor resection prior to PRRT in metastatic GEP-NET patients. Most of the well-differentiated GEP-NETs exhibit somatostatin receptor overexpression, which can be targeted by somatostatin analogs or PRRT. PRRT is a targeted radiotherapy which consists from a radioisotope coupled to the octreotide drug targeting the somatostatin receptor, and the radiation will cause the tumor to shrink. It has been proven that lower tumor burden is associated with better response to PRRT. So the question arises, is there a potential benefit of primary tumor resection before PRRT? Our clinical question is, how does primary tumor resection before PRRT affect the prognosis in patients with stage 4 GEP-NET? The population being metastatic GEP-NET patients, the intervention being primary tumor resection prior to PRRT, the comparator group being PRRT alone, and the main outcome we are looking for is progression-free survival. Our hypothesis is primary tumor resection prior to PRRT improves prognosis in stage 4 GEP-NET. The clinical implication could be improved patient outcome, survival, or even cure of the disease. Here you can see the search key used for the systematic search. We also looked for previous meta-analysis and Prospero registrations, but we found none of these. Here you can see the key articles, the population, the intervention, the comparator group being almost the same, and all the articles were looking for progression-free survival as their main outcome. 2 of the articles are prospective cohort studies, and 1 of them is a retrospective cohort. After the title and abstract selection, we selected 211 articles for the full text selection. We started the full text selection, and we expect to finish it before the new year. The second project is investigating the safety and effectiveness of surgical excision of primary tumor in well-differentiated pancreatic neuroendocrine tumors. PNETs are rare neoplasms. They account 1% by incidence and 10% by prevalence of all pancreatic cancers. So the question arises again, is there a potential benefit of primary tumor resection only in metastatic disease. Our clinical question is, how does surgical excision of the primary tumor only affect the prognosis of patients with metastatic, well-differentiated PNET patients compared to non-surgical treatment? The population being well-differentiated metastatic pancreatic neuroendocrine tumors. The intervention we are looking for is surgical excision of the primary tumor or ablation of the primary tumor. The comparator group is a systemic treatment group, and the main outcome we are looking for is overall survival. Our hypothesis is, in patients with metastatic well-differentiated PNET, surgical removal of the primary tumor improves overall survival and disease control compared to medical therapies. The clinical implication could be improved patient outcome, survival, or even cure of the disease. Here you can see the selection criteria for our study, the inclusion criteria being patients with resectable pancreatic neuroendocrine tumor, grade 1 or grade 2, with distant metastases, and the exclusion criteria being grade 3 tumors, neuroendocrine carcinomas, unknown grades, other primary sites or multiple synchronous cancers, prior radiation therapy, or incomplete follow-up information. The SEER registry is maintained by the National Cancer Institute, and it provides data on cancer incidence, prevalence, survival, and mortality. We gained access through the public use data with the SEER-STAT application. Currently, we are selecting patients for our patient registry, and up to this day, we have around 550 patients selected for the intervention group. So as a summary, the first project is at the full text selection phase. We plan to submit it next year, September. The second project is at the patient selection phase, and we plan it to submit it until June 2026. And let me finish my presentation with the words of Carl Sagan: somewhere something incredible is waiting to be known. Thank you for your attention.
Hi, I have a question. I'm going to repay you with a question. So, neuroendocrine tumors, really, really nice. I'm interested in the topic. You saw my second project. Do you think liver transplantation could have any role in neuroendocrine tumors?
Thank you for your question. It is not routinely done yet, but it is accepted in selected cases, such as the primary tumor is resected and there is no extrahepatic metastasis. Also, I read a large cohort study in which they reported the recurrence rate for liver tumors around between 30 and 50%. It is high. But I think if we can improve these numbers, it can have a crucial role in somatostatin negative tumors or in tumors where liver debulking threshold cannot be gained.
Congratulations. I really enjoyed your presentation. And my question is that what do you think about what is the mechanism behind the increased survival or quality of life after the removal of the primary tumor?
Yeah, thank you for the question. I think lowering the tumor burden results in a lower dose needed for PRRT. So the problem is when you have a tumor with high tumor burden, it has a lot of somatostatin receptors. It can happen that with a high tumor burden at the metastatic site, the PRRT cannot reach therapeutic levels. That's why primary tumor resection or cytoreductive surgery can help the PRRT therapeutic responses.
Thank you very much.
You are focusing, if my understanding is correct, you are focusing on pancreatic neuroendocrine cancer as primary, is that right?
In the second project, right.
Second project, okay. And you mentioned surgery of the primary or ablation treatment of the primary,
yeah.
Is that correct? And what do you mean by that, ablation treatment? What sort of treatment will you look into?
We have some articles where they used ethanol ablation for insulinomas and glucagonomas, and we want to look in the SEER database if someone has also done that, and we can find some results or records of that, and then we could compare it with this primary tumor surgery.
Okay, fine, but there is electroporation, radiofrequency ablation,
ethanol ablation.
So you will look only into the ethanol ablation.
I'm sorry, we will include any type of ablation of the primary tumor because it is, as far as I know, it is not done routinely, and there are few cases.
That's correct. Okay, thanks very much.